Welcome back. This is going to be the third and final section on the peripheral nervous system. And in this section, we are going to be learning about spinal nerves. So to understand spinal nerves, let's go back to the spinal cord and see what happens there. So in the spinal cord, on the dorsal side, we have dorsal rootlets, which are attached to them. And these are carrying afferent information, because this is your sensory information going to the spinal cord. And if we go more laterally, then the rootlets will all condense or be packaged together and known as the dorsal root, and we have the dorsal root ganglion attached to that. On the ventral side of the spinal cord, we're going to have an equal number of ventral rootlets, and these are going to be carrying motor information out of the spinal cord. So these are efferent rootlets, and they all condense to form a ventral root. Okay. And this is a picture of a spinal cord showing these posterior rootlets coming out, these dorsal rootlets, and their attachment to the dorsal root ganglion. And notice this is meninges, specifically this is dura mater, which has been cut so that you can actually see the spinal cord. So in this picture, we can see both the dorsal and the ventral rootlets and the dorsal root ganglion. And then lateral to that, we have the spinal nerve. So the spinal nerve is the part where we're going to have both mixed sensory and motor. So starting at the spinal cord and going lateral, the first thing we have are the rootlets, then we're going to have the roots with a dorsal root ganglion, and then we're going to have the spinal cord. Okay. Sorry, the spinal nerves. So when we look at the spinal nerves, it's as I talked about previously, we have 8 cervical nerves. We're going to have 12 thoracic nerves. We're going to have 5 lumbar nerves, 5 sacral nerves, and 1 coccygeal nerve. Okay. And when we look at what happens to these spinal nerves, it depends on what part of the spinal cord they are attached to. Going back to this picture, if you look on the left side, in the thoracic area, you see the spinal nerve come out and it just stays as a central nerve. But if you're above that in the cervical upper thoracic area, or if you're in the lumbar sacral area, what you see is all the things joining together and looking very confusing to you at this level. Okay, so let's talk first what happens to the spinal nerve before we talk about all that confusing coming together and separating out. So hopefully you recognize this picture with the body of the vertebrae close to you and the spinous process away from you, and you can clearly see the ventral root and the dorsal root with the dorsal root ganglion. And so where I'm pointing to now, that is the spinal nerve. And so if we go lateral to the spinal nerve, what we see is that spinal nerve looks like it branches into 2. And I'm going to use the word branching, although you do have to realize that if it's bringing afferent information, it's actually merging rather than branching. But since I'm going from spinal cord going out, I'm just going to use the word branching. And so each of these branches of the spinal nerve is called a ramus. Okay. And so what we are going to have is we are going to have one ramus, which is going to go posteriorly, and we're going to have a ramus, which is going to come anteriorly. So that posterior ramus is called the dorsal ramus. And so that goes to all your big muscles just on the lateral aspect of your spine, all those posture muscles which help keep you upright. The ventral ramus will come around the entire torso of the body. Okay. And then in the thoracic area, there's a third branch. So in the first cartoon drawing, it was only showing the dorsal ramus and the ventral ramus. But on this big picture to the left, this is in the thoracic area, and it's showing the third branch. And the third branch is called the ramus communicans. And what that does is that comes immediately anterior just to the side of the bodies of the vertebrae. So it's a very short branch. Okay. So if we got rid of everything else and we just left the neural components, it would look like this, where this is two spinal nerves coming out of the spinal cord, and you can see the dorsal ramus going there, the ventral ramus coming around anteriorly to the midline, and then we have the part that is becoming the ramus communicans. So looking at it, cutting out the backside of the spinal cord to look at it, you can clearly see dorsal root ganglion, where the X's are, and then you have the spinal nerve, and you can see this, the branches going out to the side. Those are the ventral rami, which will be continuing. This is in the chest area because you have ribs, and each of those ventral ramus is on the undersurface of a rib. And then the other thing you can see, parallel to the spinal cord, you can see the yellowish nerve structures, which are going in a superior inferior direction. And those are going to be branches coming off that third spinal nerve branch, the rami communicans. All right. So what happens to that ventral ramus? Well, in the thoracic area, it travels in the subcostal groove on the undersurface of the ribs. And that is going to give us a nerve between every set of ribs, and those are going to be called intercostal nerves, meaning nerves between the ribs. Okay. And so you can see that they are clearly traveling on the undersurface of the rib along with a little intercostal artery and an intercostal vein. And this has very important clinical significance, because if we ever want to enter the chest cavity, whether to put in a chest tube because somebody's had a collapsed lung or do surgery, we also always, we always will be cutting on the superior surface of the rib, because we know these blood vessels or nerves are here on the inferior surface. So we stay away from them by hugging the superior surface instead. All right. So thoracic area, it was easy. They became those intercostal ribs. So we have 12 intercostal ribs, one on the undersurface of each of the 12 ribs. Now, above this and below this, the rami form what are called plexuses. So those anterior rami, the ventral rami, they will join together, and then they will branch, and they'll reorganize how they join together, and they'll branch and they'll reorganize. And eventually you will end up with these nerves where the fibers for one nerve are not coming from one spinal nerve to become one nerve like they're doing for the intercostal nerve, where the spinal nerve coming out underneath T5 becomes the intercostal nerve going underneath the fifth rib. Okay. And so I will go in great detail to show you an example of how one of these rami, how one of these plexuses work. And for the other ones, it's not important that you learn it. Okay. So we have 4 areas of plexus, and starting most superior, we're going to have a cervical plexus, then we're going to have a brachial plexus, then we're going to have all the intercostal nerves. Below that, we're going to have our lumbar plexus, and then the lowest one is going to be our sacral plexus. So what is interesting about these rami is they are both motor and somatosensory. So I'll be talking about them as I go along. So when we are talking about the somatosensory, we're talking basically innervation to the skin. And we can map that as these beautiful drawings here in what are called dermatomes. So each of these spinal nerves, the 8 cervical, the 12 thoracic, the 5 lumbar, 5 sacral, and the 1 coccygeal, they all receive sensory input from one specific area. That area is known as a dermatome. And there is overlap. For instance, if this is the dermatome for T5, which I was mentioning before, it's about 2 inches wide. And the bottom inch is going to have overlap in the dermatome for T6, and the top half inch will have overlap from the dermatome for T4. So only part of it in the middle is only T5. Okay. And so they kind of go in a general area where you're going to start higher up in the cervical area, and then because of the brachial plexus, we're going to the upper extremity. And so by the time you return to your chest, you're in the mid-thoracic area, the upper thoracic area. And then it will continue down. And the lowest part, the coccygeal one, does the perianal skin. Okay. So long before we send patients with suspected spinal cord injuries to a CAT scan or to an MRI, we do a physical exam. And we can test sensation. And just by testing the sensation, we have a pretty good idea if the spinal cord is intact. And if it's not intact, then we have a pretty good estimate where the fracture is going to be that caused the damage just by understanding these dermatomes. Okay. So for this class, it's an introductory class. You don't have to memorize these dermatomes, but do take a few minutes, look at this in your book, look at this picture here, and understand how they are laid out in the body. And like if you were taking a subsequent class, you need to learn it and you were bored, you would just start painting your body so you understand it. And so I actually put this picture in here so you get some appreciation as to how wide these dermatomes actually are. They're not skinny little things. They're quite significant. All right. So here's the other reason why it's important to understand dermatomes, and that is the disease called shingles, which hopefully most of you have heard of. But if you haven't, I know you've heard of chickenpox. Okay. So chickenpox is due to a virus known as varicella zoster, because varicella means chickenpox and zoster has to do with the shingles. So the same virus does both diseases. And so when you have chickenpox, you have those pox lesions all over your face. If you have the disease, now you can get the immunization to prevent you from getting the disease. Because if you have the disease, what happens is the chickenpox goes away. You may have some skin scarring from it, you may not, but the virus stays in your dorsal root ganglion, okay, where those sensory cell bodies are located, and it remains dormant in there. And then much later on in your life, it can be reactivated. So what does it take to be reactivated? Stress, okay? For instance, the stress of the pandemic of 2020, okay? Stress of a marriage, a divorce, a death of a loved one, okay? Buying a house, selling a house, final exams, okay? Any kind of disease process or any kind of immune compromise, all of those things can reactivate this virus. And what it does when it's reactivated, it's going to travel along the sensory nerve fibers and cause the disease called shingles, whose real name is herpes zoster, thus the zoster of varicella zoster. And so you can see all three of these pictures are showing dermatomes. Yes, I have two from the chest area. The one on the left is to show you the acute stage where we have these blisters, okay? And these are extremely painful. It's as if you have all the blisters of a burn all along the dermatome. There's no cure for this, okay? It's gonna take weeks for the blisters to go away, and it can take months or years for the pain of this to go away. It's extremely debilitating. So get your immunization against this, okay? And in fact, nowadays, we actually will re-up the immunity against reactivation by, congratulations, you've turned 60. Here is a zoster's vaccine, which is slightly different than the chickenpox vaccine, okay? It's not quite the same dosages, okay? But it's essentially very similar to the chickenpox vaccine. because we really want to prevent this disease. It's incredibly debilitating, causes a lot of skin lesions and a lot of pain, and people end up not working. And if you had a diagnosis of cancer and you're trying to get chemotherapy, having an acute case of shingles is the last thing in the world you need. Okay, so let's get back to the topic at hand. Let's talk about those plexuses. So the most superior plexus is the cervical plexus, and this plexus comes from spinal nerves 1 through 4 in the cervical area. And I think you clearly can see the nerve roots coming out here, and they're branching, and then they can recombine, okay? And it's not important to know what's on the left. On the left is just showing you what it is. And for each plexus, not only do I want you to know what it's called, general area of the spinal cord that it came from, but I will tell you if there are important nerves. Like, you don't have to memorize all those nerves listed on the left. And so this one, when it comes out, will travel actually deep to the sternocleidomastoid muscle here. And then the only nerve we're going to learn has nothing to do with what's going on in your neck, but it has to do to a nerve that enters your thoracic cavity. It travels between your lungs and your heart, and it innervates the diaphragm. And that nerve is the phrenic nerve. So the phrenic nerve gives motor to the diaphragm. So in other words, if you want your diaphragm to contract, you need your phrenic nerve intact, and it comes off your cervical plexus. So if you have a high cervical injury and the cervical plexus isn't getting any messages, then your diaphragm can't contract. That means you can't inhale. That means it's not going to be a good day for you. So that's the cervical plexus. The brachial plexus starts in the mid-cervical area, C5, and it does 5, 6, 7, and 8, and then it includes the first thoracic spinal nerve as well. And it's going to travel between some landmark muscles you learn about in lab that have to do with breathing. And from there, it's going to go and be forming nerves which go into your upper extremity. And these fibers are going to separate and recombine several times. Anybody feeling tired? Because this is detailed work, so I'm feeling it. Okay. However, that's not why these words are here. These words are here because this is your mnemonic. Really tired, drink coffee now. So take the first letters, R, T, D, C, N. Because this is the one where we are going to learn a little bit of the detail about how this plexus forms. Okay. So I'm going to go through it in all the detail. Well, I'm not going all the detail. I'm going to go through it in a fairly significant amount of detail. And then once I'm done with that, I'll tell you what it is exactly you need to know. So these are the relationships that we find in the brachial plexus. So over here on the far right is where the spinal cord would be. Okay, and you'd have your dorsal ramus, your rami communicantes coming up the thoracic area. And then we have our ventral rami. So the R of really stands for rami, specifically the ventral ramus. And so here we are, C5, 6, 7, 8, and T1. So there's 5 branches that are coming out of the spinal cord. And what you'll notice is the upper 2 are splitting and the bottom 2 are splitting. Sorry, not splitting, are joining together. The upper 2 are joining together and the bottom 2 are joining together. So we're going from 5 rami to only 3 structures. And those 3 structures are now called trunks. That's the T. And so the higher 2 rami form the upper trunk, the lower 2 form the lower trunk, and the one in the middle stays by itself. Then what happens is each of these trunks is then going to divide into an anterior and a posterior division. The D is for division. Okay. So we've gone from 5 rami to 3 trunks, and now we're going to have 6 divisions. And so it's kind of cool what happens here. All 3 of the posterior divisions are going to merge together and form one structure. The more superior 2 anterior divisions are going to join together, and then the lowest anterior division is going to stay by itself. And those are going to form what we call cords. So we're going to go from 6 divisions to 3 cords. So of the cords, 2 of them are carrying anterior division material, and then 3 are carrying, I'm sorry, 1 is carrying all the posterior division stuff, which actually came from all 3 of the trunks, which actually came from all 5 of the rami. Okay, so all 5 of the rami are now given content into the 1 cord. Then what's going to happen, that posterior cord is going to split into 2. That lateral cord is going to split into 2, and the medial cord is going to split into 2. But what's going to happen is these 2 are going to join together, and we're going to have like an M with 1, 2, 3. Do you see the M? Okay. And those are going to be the nerves. Okay. So what do you need to know? Really tired, drink coffee now. You need to know ventral ramus, trunks, division, cord, nerves. You do not need to know upper, middle, lower, anterior, posterior, lateral, medial, posterior. You do need to know C5 through T1, where the ventral rami are coming from. And then at the other end, you're going to need to know the 5 peripheral nerves, which we're going to go through in more detail than you ever wanted to know. Okay, so you're going to need to know their names, and you're going to need to know generalities of what muscles they're going to innervate, as well as where their sensory stuff is going to. But the whole point of this plexus is, even though we started with 5 rami and we ended with 5 nerves, they are not 1 to 1. Okay, so there are fibers from all 5 of the rami that are going to 2 of the nerves, and then there's fibers from the other ones going to the other 3 nerves. So yes, they're all mixed up. So what does this mean? This means if, for instance, you were to cut one of those rami, you would not lose function in any one of those 5 nerves. You would lose a slight amount of function in multiple of the nerves, but generally the nerves would still be intact. So that's the advantage of a ramus. Okay, so just learn the really tired, drink coffee now, C5 through T1, and then the 5 nerves, which we're about to go through. So here's a picture of the neck showing, I know it says roots, but think rami, really tired, drink coffee, and here are the 5 nerves, okay? Not important to learn the names of the trunks, divisions, or cords. All right, so let's get back to that M. That M sits anterior to a blood vessel, right here, where we're going to have the subclavian artery become the axillary artery. And so this is where 2 and 2 join together to form the M. Okay. The other 2 nerves sit posterior to it. So do you see how we have 1, 2, 3 nerves anterior and 2 nerves posterior? Is that you need to keep in mind. There are going to be 3 nerves which are going anterior, and there's 2 nerves which are going posterior. So the anterior nerves are going to be starting laterally and going medial, the musculocutaneous, then the median, then the ulnar nerves. And then the 2 posterior nerves, the big one is the radial nerve, and then the axillary nerve is a branch that comes off the radial nerve. So let's see how that looks in a drawing. So go back up here in the armpit area. Does everybody clearly see the M with the 3 nerves? Okay, so musculocutaneous, median, and ulnar, lateral to medial. And then in green, those are the 2 posterior nerves. Up here high, we have the axillary nerve, and then going down posteriorly, that green, that's going to be the radial nerve. So that's the anterior view. On the posterior view, basically what you're seeing is the axillary nerve up high, and everything going down is going to be radial nerve. We are not learning the branches of any of those 5s. We're just learning those 5s. So here is the slide that talks about all of them. So what is you need to know? Well, for lab, you learn your innervations of the muscles, but let me kind of go through these one by one through the 5 nerves to make sure we're all on the same page as far as what you need to know. And for this, I'm going to put my glasses on so I can see. The first thing has to do with the musculocutaneous nerve. Okay. And so It is going to be doing some anterior arm muscles. Okay, so if you know your anterior arm muscles, then you know that those are the ones innervated by that. And if you haven't learned them, everybody knows the biceps brachii has an anterior arm muscle. So that is that one. Okay. In addition, I'll do the sensory after I do the muscle things. The median nerve is going to be giving us pretty much all of our anterior forearm muscles, with the one exception of the anterior forearm muscle that is on the ulnar side, which would be the ulnar nerve. So all of those wrist flexors are going to be median, except for the flexor carpi ulnaris, okay? The flexor at the wrist on the ulnar side. Posteriorly, up here, your deltoid, that's going to be your axillary nerve. And then every other posterior muscle is going to be your radial nerve. Okay. So let's talk sensory. Sensory up here, axillary. Okay. Posteriorly, back here, everything is radial until you come to the hand area. And in the hand area, it is going to be 3 digits posteriorly are going to be radial. Anteriorly, let's talk about the hand. The lateral 1.5 digits are going to be ulnar nerve. And the ulnar nerve is going to be both anterior and posterior. Okay, that's why radial was only doing these 3 here. On the anterior surface of the hand, 3.5 digits are going to be median nerve. Okay, so median, ulnar, radial. So ulnar gets everything on the ulnar side. Median gets everything anterior in the hand, and radial gets everything posterior in the hand, as well as everything posterior up there. All right. So why are we learning these nerves? Okay, so radial nerve injuries are common in a couple different ways. For instance, because it's traveling posterior, it's actually right next to the humerus. So mid-shaft humeral fractures are very common causes of radial nerve injuries. And if you recall, the radial nerve is doing all of these muscles back here, which are all going to be extensor muscles, which means if you have fractured that, you're not going to be able to extend your wrist. So your hand will be permanently like this guy's hand, like that. You lose the function of all those extensors. Now, you don't have to just injure the radial nerve there. You can injure the radial nerve, for instance, if you fall asleep on your hard textbooks with your hard head, you can squish it there. That's usually just a temporary thing. It'll come back. Also, people who wear elastic hairbands, ladies, or wristwatches that are too tight on their wrist, you can cause a radial nerve injury at the wrist level. Ulnar nerve, the classic ulnar nerve injury are in bike riders who are leaning on their handlebars, because your ulnar nerve comes right here. You know, when you're hitting your funny bone, right here between the ulna and the humerus on the lateral aspect, that's your ulnar nerve. And then it comes down here, and it actually comes anteriorly. It goes posteriorly, just go around. So it starts anteriorly, goes behind your elbow to get around your elbow, and then it comes back anteriorly right down in this area. And so if you're leaning on your bicycle handlebars, you can get weakness of hand muscles, plus you can get a decrease in sensation for your 1.5 digits. And remember that that's going to be a sensation defect, not only on the anterior surface, but also on the posterior surface. Now, the carpal tunnel syndrome is totally related to the median nerve, which is coming down here in the middle. And that's because it has to dive under this band of connective tissue here at your wrist, where all those flexor tendons are. And so as you work on your computer with the typing, they're all getting enlarged and inflamed. The same thing on your phone if you're scrolling back and forth, swiping right, swiping left. And so the softest structure that is located in there is that nerve, which is the median nerve right in there. And so if you look at the cross section at the wrist, what you can notice is posteriorly, you have your carpal bones. You've got your wrist bones, so there's no place for anything to go. And so the softest, squishy thing is that median nerve. Now, this normally what's going to happen is sensory deficits long before motor deficits. However, some people don't go see their healthcare provider until they have the motor deficits, which is really bad because you may not get those motor deficits back. But if you go while you're still having sensory deficits, you almost always will recover median nerve function. And the way this is treated is by basically cutting that tough, dense connective tissue, which is overlying it, just unroofing it to give more room for the median nerve. And then, of course, you know, you cut the dense connective tissue, but you reapproximate the dermis and the hypodermis above it. All right, so with that we are done with the brachial plexus. Moving on to the lumbar plexus now. So this is L1 through L4, okay? And what happens in this area is we are going to have two nerves. And what I need you to remember is the lumbar plexus nerves come out on the anterior aspect of the thigh. So the first nerve actually travels through a foramen, through a hole in your coxibone, in your hip bone, that obturator foramen, and that's where it got its name, because the name of this nerve is the obturator nerve. And the obturator nerve goes to the medial aspect of your thigh. And so it is going to be innervating all of those muscles which are doing hip adduction. The other nerve in this area is called the femoral nerve. So the femoral nerve, if you notice on this picture on the upper left, is this green nerve, which is lateral to this yellow one, because this is the right side. And so the femoral nerve comes out lateral to the obturator nerve. It does not go through the obturator foramen, it actually goes over the bones and then goes to the anterior thigh area. So when we look at these two nerves, the femoral nerve is giving innervation to all those quadricep muscles plus a few other ones, whereas the obturator nerve is giving innervation to all the muscles that have to do with adduction. Looking at the skin innervation, basically everything in the medial aspect of your thigh, where the two thighs would touch together if you were adducting them, that's going to be sensory innervation of the adductor of the obturator nerve, whereas anterior thigh and continuing down the medial aspect of the leg, that's all going to be femoral nerve. So how do you injure these? Sometimes pelvic fractures can affect the femoral nerve. The obturator nerve is really hard to injure because it goes through that huge foramen and there really isn't anything significant. So you really would have to have a massive fracture of the pubis in order to injure that. So our fourth and final plexus is the sacral plexus. And so remember, the sacrum is that triangular bone that's like in the plumber's crack area of your body. So the nerves coming out of the sacral plexus are going to be posterior. Lumbar plexus, anterior. Sacral plexus, posterior, and there's only one nerve. And the size of that nerve is the same size as your pinky finger. And that nerve is called the sciatic nerve. So if you know your landmarks, then you learn of the coxal bone, you learn about the sciatic, greater sciatic notch. That's where the sciatic nerve goes. But more importantly is where it comes out posteriorly. And then it will travel posteriorly to the mid-thigh area. before it splits into the two branches. And the two branches are the more medial tibial nerve and the more lateral common fibular nerve. So looking at the tibial nerve, this one is innervating your hamstring muscles in your posterior thigh. And then it's both of these will do some of your posterior calf muscles, okay, and lateral calf muscles. The lateral calf muscles would be obviously on the common fibular nerve because it is the lateral nerve. Looking at the sensory innervation laterally, you're going to have common fibular nerve, and then posteriorly, we would have tibial nerve. So, sciatic nerve often gets injured when we have a ruptured disc in the lower lumbar area because it impinges on this nerve. Okay. And so that is going to give you a pain posteriorly, a pain in your buttock area and or traveling down your posterior thigh where the branches are. So with that, I am done with the peripheral nervous system where we learned a lot about nerves, and I am just going to encourage you to make flashcards if you're a flashcard kind of person, and just to practice and review this material as much as you can. If you're taking lab, I know there's overlap of this with lab, but this is kind of important information. And thank you for all your hard work, and I will see you again in class soon.